Dr. Tuttle, you're ready. Why don't we go ahead and kick things off? Dr. Logan is running behind in his clinic, so he'll come and join me here in a few minutes. But I think we can go ahead and kick off here. First of all, welcome everybody. We are very excited to have not just our primary care groups here, but joined. I'm seeing several members of our division of nephrology as well. And so, as always, our goal with these types of our primary care going rounds is to make it conversational, interactive, and that sort of thing. So please put questions or comments in the chat. John and I always come with cases and plenty of questions if we need to, but we find that it is a much richer conversation if we kind of lean into what everybody's really interested in and that sort of thing. We got a great expert with us today. And this is a great time for us to get some of those questions answered in our clinical practices. So today we're joined by Dr. Catherine Tuttle. So she is back by popular demand. So I sent that out in an email this morning. She came to Kansas City and joined us for internal medicine grand rounds in the fall, and it was one of our best grand rounds that we've had in a long time, and really thought-provoking. And I think we'll cover a lot of those same themes today, and our goal is just to improve the care that we're doing here with our primary care groups in our community. So Dr. Tuttle is the executive director for research at Providence Inland Northwest Hospital, or Northwest Health, I should say, regional principal investigator of the Institute of Translational Health Sciences, and a professor of medicine at the University of Washington. She oversees a regional network of 17 clinical research centers, chairs the research regional executive council for the University of Washington. And Dr. Tuttle trained in a lot of our most prestigious institutions around the country. She earned her medical degree and completed her internal medicine residency at Northwestern in Chicago. She did a fellowship in metabolism and endocrinology at Washington University and decided to do a second fellowship in nephrology at the University of Texas. And so I could go on and on about her, how many articles she's published and all that, but I think suffice it to say, she is really a top expert in this field, and we're really honored to have you with us. So thank you, Dr. Tuttle, for joining us today.
Well, thank you, Dr. Comfort. It's good to join you all, and really an honor to be invited back. And what I thought I would do is give a presentation to really set the stage of the current state of care for people with CKD and really focus on it through a primary care lens, and then join you in your case discussions and talk about patients that you see every day so we can really bring some truly transformative advances to life for people, in their communities. So let me now once again attempt my screen share. Had a little bit of a technical problem, but I think we're going to be able to make it work one way or another. You'll see yourselves for just a second before I flip. We'll try to do the presentation mode. Yes, it keeps reverting to this view. If you don't mind, I think I'll just leave it. We tried to swap it and it just wasn't working. So rather than wasting time on that, if you'll just bear with me and see, you can see the slide to come on the right. So in any case, what I thought I would focus on today are really what I hope are practical matters, but really set the stage with the background and the science so you know what you're doing and why you're doing it. And it's not just a blind protocol, so to speak. So here are my disclosures. They're all related on the topic of diabetes, chronic kidney disease, and cardiovascular disease. So three major goals today. I want to set the stage with defining for you really the public health crisis that has become CKD, the scale, the risks, the mechanisms, relationships to diabetes, but not exclusively diabetes, the need to identify strategies to increase awareness, detection, and intervention, which is squarely rooted in primary care, and then understand the new therapies, SGLT2 inhibitors, non-steroidal mineral corticoid antagonists, and GLP-1 receptor agonists. And I'm not even saying progression of CKD anymore. I'm saying preserve kidney function and save lives, because that's what really matters to patients and communities, and to those of you who care for those people. So this really has become a public health crisis. Worldwide, we know from the Global Burden of Disease study that there are 800 million people currently estimated to have chronic kidney disease. This is 1 in 10 people in the entire world, one of the most common chronic conditions. The death rate has been increasing progressively. Between 1990 and 2017, increased more than 40%. And more recent estimates by Global Burden of Disease, where they rank frequency of cause of death. By 2025, in the 2019 to 2025 timeframe, CKD had become the 9th leading cause of death, up from 19th in just 2013. And if we don't change what we're doing, it will be the 5th leading cause of death worldwide, 2040. So it really is an enormous and largely under-ignored relative to the scale of the problem. This is also from the Global Burden of Disease study. And by the way, these estimates were just published in the Lancet like 3 months ago. These are the most current estimates worldwide. But I also pulled out the US data. So the paper was published in late 25, but the estimates went through databases of 2023. 40 million people in the US, 147,000 deaths. Also, this is 1 in 7 people in the United States. So again, for those of you in primary care, this will be one of the most common chronic conditions within your practice, whether you've actually seen it or not. And if we walk back to the problem, I'm not going to exclusively talk about diabetes, but I think we need to spend some time on diabetes because this is really at the center of the problem. These estimates on worldwide diabetes prevalence come from the International Diabetes Federation. Their last estimates were made in 2021, and then they've done projections to the future. So this is the 2021 estimate. The but is that I didn't put on this slide. They've estimated, again, if this situation doesn't change by 2050, this number will exceed 1 billion people in the world. So again, you all are in primary care. You know a lot about diabetes prevention, but sadly, it has not translated in a meaningful way to communities. So we only see more and more people with diabetes. And living with diabetes means living with diabetes complications. 4 of 10 with type 2 and 3 of 10 with type 1. A smaller but still important population will develop so-called diabetic kidney disease or kidney disease attributable to diabetes, which now makes it responsible for half of all that CKD in the world. The other piece is that our traditional focus has been that CKD leads to kidney failure, which is true. But what we failed to recognize until more recent large epi studies is the enormous competing risk, and that is the competing risk of death and cardiovascular disease. And it's not just atherosclerotic disease, it's also heart failure, such that 9 out of 10 people with diabetes and CKD will die on the road to kidney failure and never make it. In fact, the group that makes it to kidney failure, you could say, is a ragtag survivor band of just 10%. You might say, congratulations, you survived if you make it to dialysis. This is also from one of our studies, just illustrating this to you. I don't want to belabor the details of the analyses, but really to show you real world data on competing risks. So this is from our large Cure CKD registry cohort. We had nearly 620,000 people with diabetes who were followed over the decade. This would be 10 inclusive years from 2013 to 2022. Death is in black and kidney failure is in red. So overall in the population, the death rate over time is twice as high as the rate of kidney failure. But then if you look at levels of GFR where they entered the cohort from normal to above 90, progressively down to stage 4 CKD or GFR between 15 and 29, what you see first of all is the black and red lines just keep going higher and higher. So risk of death and kidney failure both increase progressively with decline in GFR. But death outpaces kidney failure 2 to 1 until you get to the range of GFR of 34 to 44, where it's basically even Steven. And it's not until the GFR drops below 30 that kidney failure becomes the dominant risk. So this is a representation of competing risks. And what has happened here is the susceptible people to death have already left the cohort so that then they can live to get the terrible complication of kidney failure. But that said, the death rates still remain very high. And what we haven't shown you here is once they go on to dialysis, the enormously high death rate. So even if they make it to dialysis, only 50% of people who initiate dialysis with diabetes will be alive at 2 years. So this is a highly fatal condition, and I spend time on it because when we think about the things that you're concerned about and we're concerned about, screening for cancers and cardiovascular risk prediction, the reason we have an urgency is we know that those conditions kill people, and if we don't do something about it, they're going to have a bad outcome. We have not had that urgency. We've talked about CKD being slowly progressive. If you just look at kidney failure, maybe that's true, but when you look at the real events that happen to people, it is an urgent problem and it's an urgent mortality problem. So if we look at awareness, these are community-based studies from various surveys, and they've been done in countries around the world, including the United States, like from our NHANES database. 80 to 93% of people with CKD are unaware. And the people who, the 20% awareness comes from people with advanced stage CKD, CKD4. And then this maps to undertreatment, and it's even conventional risk factor control. You might think that RAS inhibitor use doesn't look too bad at 70%. This is actually from our data set, but the truth is that if you look at even 6 months down the line, half the people come off of these therapies, right? And you know why? They get admitted to the hospital. Their ACE or ARB is stopped, or they have hyperkalemia, and nobody thinks that they should restart the drug. Then when you look at use of drugs like SGLT2 inhibitors, now this is admittedly data from a few years ago, it still was less than 10%, and very few people are getting healthy lifestyle advice. So the low awareness of patients also reflects low awareness of the people who are treating them, and they are markedly undertreated. If you look at a recent paper looking at this is just sorry, I'm going to be catching a plane in a little bit, so I'm working at home until I go. You're hearing my dog in the background. Uh, This is data from NHANES on CKD awareness, just showing trends over time. And you can see in most US adults, the black dot, really, we have not improved over a decade. There's been a slight uptick, at least in the population who have cardiovascular disease, recognizing that their kidney health is also important. But overall, you see very low awareness, still less than 20%, just as we had seen from data sets in other countries. So how do we identify CKD? Again, back to basics. It's 2 tests, not 1. It includes some estimate of GFR, usually based on serum creatinine. I know you have a question for me on cystatin C. We'll leave that for the discussion, but that's not the only test we need to do. And we get these opportunistically, right? Because on almost every chemistry panel, there's a creatinine. And so we do pretty good at surveilling for GFR, but albuminuria, at least traditionally, has to be intentionally measured. And again, even in the diabetes population, we see annual rates of testing no higher than 50% and as low as 10% in some real-world cohorts. And it's important because both are used for staging. So even people with a GFR of 90 who have a UACR that's high, over 300, are in a very high-risk category, as represented in the red box. So albuminuria alone indicates CKD and can indicate high-risk CKD. And then, of course, anything that moves the GFR down or the albuminuria higher increases risk. And the heat map, in addition, it's kind of hard to see perhaps in this projection, but there are at least high-level actions, right? And this is meant for primary care use. Treat, treat, treat. If they're still in the green boxes, normal albuminuria and GFR, keep screening every year because if things change, you need to take action. But we also recommend that if they are in very high-risk categories, represented by the lighter and darker red, that there really should be a referral. And this doesn't mean that you're not still managing the patient. It just means that it needs to become a team sport. And nephrologists, and in some cases cardiologists, need to join the team along with you. And remember that this heat map, I will not belabor all the background data, certainly is high risk of losing kidney function or kidney failure, but also portrays cardiovascular event rate risk, that's heart failure and atherosclerotic disease, and all-cause mortality. So if you end up in these dark red boxes, you're at very high risk of being on those trajectories that I just showed you from our real-world data set. This is an earlier version of registry data, but just demonstrating that we've had recommendations on albuminuria testing for at least 3 decades. But even during this time period when those were established recommendations, whether we looked at CKD as a whole or subsets of super high risk, such as those with diabetes, prediabetes, hypertension, at best we were testing only 20%. So lots of room for improvement all over the place, including where I work. If we go to the KDIGO guideline, and by the way, I want to disclose that this guideline has been updated, but not yet published. I'm a member of the committee. So I'm going to stick with the published guideline, but I will also show you where you can expect to see changes. And all of this data is in the public domain, so I think it's fair game to discuss what will change as well as what is currently published. So, of course, the guidelines recommend they use this paradigm, a pyramid paradigm. So, healthy lifestyle, including physical activity, diet, weight management, smoking cessation among smokers is always recommended. That's recommended for good health, no matter what condition we're concerned about. First line therapy was recommended to include SGLT2 inhibitors as first line. This was first in the diabetes guideline, now in the general CKD guideline that is carried through because even in non-diabetes patients, SGLT2 inhibitors are highly kidney and heart protective, and I'll show you a little bit of that data. But also remembering that even in the CKD population, our remit is also to reduce cardiovascular risk, so these patients should indeed get statin therapies or other methods to get cholesterol to goal. Metformin still is a good first-line therapy if their GFR is adequate and needed for glycemic control, but not required if not needed alongside an SGLT2 inhibitor. Then note the arrow to regular risk factor reassessment. This is not one and done or fire and forget. We should be reassessing risk factors every 3 to 6 months. And yes, that means blood pressure, glycemia, lipids, but also albuminuria and GFR, because if those remain in high risk ranges, we will add additional what we call risk-based therapies. So that could include a non-steroidal mineralocorticoid antagonist. I'll show you the data and recommendation on that more specifically. And now also GLP-1 receptor agonists. And depending on cardiovascular risk, they may also need to have antiplatelet therapies added. Again, I know this is a primary care audience, but I do want to take you back to a little bit of the fundamental basis of disease, because as you're applying guidelines, I think it is helpful to understand what it is you're actually trying to treat. And structure does beget function in virtually every organ, including the kidney. So let me just take a moment to show you what we're trying to address at a structural level. So these are the glomeruli. You probably remember these from like second year pathology. And these Kimmel-Steele-Wilson nodules are the sine qua non of, quote, good old-fashioned diabetic nephropathy. This is just an electron micrograph that magnifies a picture here showing the interface of the mesangium, which is in the middle, and a capillary loop. And the basement membrane here should be thin and continuous, and you see it's broken and thickened. And this is the structural basis of why albumin leaks into the urine and why GFR declines. It's an ineffective filtration barrier. But the kidney is 90% tubulointerstitium, and this is a normal tubulointerstitium, nice, pristine, pink. This is a sick tubulointerstitium in diabetes. In between the tubules, there's a lot of pink stuff. That's scar or fibrosis. There are a lot of purple dots. Those are immune cells. I'm bringing that up because all of these have become targets of the therapy you're using. And then, of course, the arterioles are unhealthy too. This is thickening. This is the sine qua non of the hypertensive component. So when we start treating, we're going after all of these mechanisms, and I'll harken back to those when we talk about the treatments. So as a schematic then, in people with CKD, diabetes is a dominant factor. It often comes with other risk factors. For example, 90% of people with diabetes and CKD have hypertension. You can also get CKD from other causes, but the bottom line is that irrespective of the initiating cause, they drop down into metabolic, hemodynamic, and pro-inflammatory and fibrotic mechanisms. all of which, again, I'm not going to belabor this, feed down into what I'm going to call the box at the bottom, which is inflammation and fibrosis factors. And it occurs in those various cell types and compartments. And the treatments we use are now designed to hit metabolism, hemodynamics, and directly inflammation and fibrosis, because that is the mechanism of kidney damage onset and progression. And yes, we're starting with diabetes, but I want to be clear that diabetes simply opened the door to understanding that whether diseases, other causes of kidney disease occur concurrently or independently, we end up with common progression factors. But that actually is the opportunity to have highly effective therapies that work across multiple primary causes of CKD. So now let's go back to something probably more familiar, which is the treatment of patients, in this case with angiotensin receptor blockers. And for historical context, hard to believe it's been a quarter of a century ago, this was the first demonstration that beyond conventional risk factor control, in this case hypertension, that a specific class of drugs could provide kidney protection. There had been a lot of preclinical work done, but these were the defining clinical trials done in large populations with type 2 diabetes and established chronic kidney disease. There was the RENAL trial that tested losartan, ID&T tested irbesartan, and also included amlodipine as an active blood pressure control, because indeed these agents were originally developed for the treatment of hypertension. The question was, is it hypertension alone, or is there a protective mechanism of inhibiting angiotensin beyond blood pressure control, which is what the models, preclinical models, had repeatedly shown. And so for the first time, we see that the risk of true clinical outcomes was reduced 16% in RENAL and 20% in ID&T, showing that there was benefit specifically of inhibiting angiotensin II beyond just blood pressure. Now that was heralded as an advance at the time, but you see there's still large residual risk, the people on active treatment who are still progressing. And you see at 48 months, this is still, in the range of close to 50%. I've dropped arrows in at 30%. They're lower at that time point, more in the 25 to 30% range, because risk accrues with time. And the reason I've dropped that in is I'm going to contrast it with the newer agents where the trials have been shorter, and I'll tell you the reason why. But just remember that those were the residual risks. And also when you think about the underutilization of therapies, remember I told you that even if at a single point in time, 70% of people are getting these agents, in 6 months, it's only like 40%. Most people have not benefited optimally even from these older agents. But what was really transformative was the advent of the new glucose-lowering therapies in the field. And these came to clinical medicine through the cardiovascular outcome trials that were mandated by the U.S. Food and Drug Administration to prove safety of new glucose-lowering agents. Why did that occur? Well, there was something called the rosiglitazone debacle in 2006, where the drug was placed on the market for treatment of type 2 diabetes, but within the first year after it was used, there were a number of reports to the FDA about adverse cardiovascular events. Initially, they were focused on MACE or atherosclerotic events. So they mandated that if a new drug was put on the market for glucose lowering, that the sponsor had to do a post-market approval safety study to maintain the drug on the market. And there had been hints of this before. There were the sulfonylurea agents, which were never studied with the rigor that we study new drugs today, had also been associated with cardiovascular events. So there was a lot of sensitivity about safety of glucose lowering agents. But this really turned the world on its head 180 degrees, because not only were these drugs safe, they were highly effective. They reduced major adverse CVD events, and they were not only atherosclerotic events, but even more dominantly heart failure events. And two agents in the class, empagliflozin and Empareg, the first CVOT, and dapagliflozin in the DAPA heart failure trial, one of the early heart failure trials, also for the first time showed a benefit on cardiovascular death. So this was really a remarkable turn of events. The major secondary outcomes were kidney outcomes, and across the board they decreased onset of macroalbuminuria, that's high level albuminuria that would put you in a red KDIGO heat map box. GFR decline, and kidney failure. And the kidney and cardiovascular benefits were present even in that highest risk group who had both CKD and diabetes. So then there was an explosion of clinical trials from about 2019 through 2023 in heart failure and CKD, but I'm going to primarily focus my comments on the CKD trials. Every one of these trials was stopped early for overwhelming benefit. That's really amazing. In the field of nephrology and in most fields of medicine, this is a very rare event. It had never occurred in nephrology before. And notably, the trials studied broader and broader populations. So in Credence, it was all type 2 diabetes. They had to have a UACR over 300 and a GFR of at least 30 or higher. In DAPA CKD, they enrolled 1/3 without diabetes, so multiple causes of CKD. They went down to a GFR of 25 and a UACR of 200. And then finally in IMPA kidney, we went down to a GFR as low as 20, and they didn't even have to have albuminuria, and 51% did not have diabetes. But the results were exactly the same. You see hazards ratios of 30 to 40, of around 0.7 to 0.6, so 30 to 40% relative risk reductions on top of background use of ACE or ARBs that were used in 98% of the patients. So then you see that residual risk that had been about 30% ratcheted down to about 20% at 30 months. So while these are really remarkable clinical benefits, the problem is that there's still residual risk and not very much time has passed in these trials. So we can project that over time that's going to continue to go up. So this is important, but the job is not done solely with an SGLT2 inhibitor. One comment about heart failure, because it is a major cause of death, particularly in people with low GFR. This is from the DELIVER trial, which was the second dapagliflozin trial that studied people with preserved or moderately reduced ejection fraction, now the most common cause of heart failure and the one most closely associated with diabetes and CKD. And you can see across the range of GFR, there was comparable heart failure benefit. And in fact, if you looked at the low GFR subset, with a GFR between 45 and 60 in this trial, they had even larger benefit, hazard ratio of 0.68 versus 0.84. And look at the number needed to treat at 3 years was just 18 versus 33 with normal kidney function. So the point is that people with CKD get as much, if not more, benefit on heart failure, which is important because the competing risk to kidney failure is heart failure. How does it work? Again, these studies were really remarkable in publishing the GFR trajectories. Every one of them has published these, but I will just pick two as examples. IMPA-REG, the first CVOT, and Credence, the first kidney trial. You see this exact same pattern in both abrupt GFR decline followed by stabilization. That's true whether they started at a normal or reduced GFR. And this is the hallmark. It occurs very quickly of reducing glomerular hyperfiltration. And just again, for a moment here, I'm going to take you back to physiology. Why do we care about that and what does it mean? This is helping you understand the GFR dip and to not fear the dip. It actually can be used as a readout for therapeutic responsiveness. So if we go back to early diabetes, and actually it carries through in diabetic kidney disease and other forms of CKD when there's nephron dropout, we have glomerular hyperfiltration at the single nephron level. There's more blood flowing in, and there's on the inflowing side, and there's vasoconstriction on the outflowing side. This is the only capillary circuit in the body with an arteriole on the up and downstream end, which means it's under high pressure. High pressure is very damaging to these delicate capillary circuits. And in diabetes, teleologically, it's thought that SGLT2 transporters, which exist in one and only one place in the body, which is the proximal convoluted tubule, are upregulated to reclaim lost glucose, so people don't starve to death by peeing out their glucose. That also requires sodium uptake, which means when you get downstream, where the nephron comes back close to the inflowing artery, there's less reabsorption of sodium. And that's important because it uses ATP, which generates adenosine. In this case, it is not an innocent waste product. It's a very active paracrine factor that hops next door, binds the type 1 receptor, and is a vasoconstrictor. So in diabetes, we've lost the brake and we have unfettered hyperfiltration, and that occurs at the single nephron level, so you might not see an elevated total GFR. When we give ACE or ARB, we dilate the downstream or the efferent arteriole, but we've left unattended the hyperperfusion. When we give an SGLT2 inhibitor, we block at this site, we increase distal delivery, and we reactivate the brake. That's what the GFR dip is, and that's why it is protective over time, because it's reducing single nephron, or you can think about it as local hypertension that you cannot address with a systemic treatment. What the heck does this have to do with heart failure? Well, everything I've told you is right here, but it really unlocks this synergy between kidney and cardiovascular physiology that has a lot to do with regulating heart function. And again, if you want to read in detail, Dr. Braunwald, the legend in cardiology, wrote a beautiful treatise about this in the New England Journal of Medicine of why a kidney mechanism could have such profound effects to preserve heart function. But suffice it to say that these mechanisms that occur in this tiny section of the nephron have far-reaching systemic effects. As a result of that physiology, for example, there's a reduction in plasma volume, there's a diuretic effect, lowers blood pressure, there's an increase in erythropoietin and oxygen carrying capacity, and also the mild ketosis, which results from glucosuria, generates beta-hydroxybutyrate, which is a preferred myocardial fuel. And then in turn, when cardiac function improves, we see improvement in kidney function. So we've unlocked a pathophysiology that links CKD with heart failure, particularly preserved ejection fraction heart failure, where the primary defect is not in the myocardium, it's in systemic factors that cause the heart to fail. Okay, now back to reality. I hope I didn't completely disorient you with all that, but I think it's worth taking a moment. So if we go back to guidelines and what we should do after first-line therapy, remember, after we start with our first-line therapy, ACE or ARB, statins, SGLT2, metformin if we need it for glucose control, what do we do next? Well, if there's persistent albuminuria, then we're going to drop into, and I mean above 30, not above 300, we're going to drop into another therapy, first nonsteroidal MRAs, and then we'll talk about GLP-1 receptor agonists and where they come in for metabolic, cardiovascular, and kidney benefits. So, at the same time we were doing the SGLT2 trials, finerenone, which is a nonsteroidal MRA, was under study for CKD and type 2 diabetes. These trials were also successful. They were performed in CKD with type 2 diabetes, but in Figaro it was less severe. So they put primary cardiovascular outcomes. So GFR here on average was 60, UACR was 100. So more of a moderate risk group from a KDIGO standpoint. In this group, the GFR was 45, UACR was 600, and the kidney outcomes were primary. But both of them won. Hazards ratios of 0.87 and 0.82, not quite as pronounced as SGLT2. These are not head-to-head comparisons, but I think it's fair to say that they're additive therapies. And this is from the late, great George Bacris, who we lost soon after the publication of these studies, showing a similar analysis to what I showed you from DAPA heart failure. Across ranges of CKD severity, whether assessed by higher to lower GFR or lower to higher albuminuria, this is the risk reduction. The confidence interval was consistent. But the important thing to recognize is if you look at absolute risk, which is represented by the bars, absolute numbers of cases, the highest risk groups with placebo in red are, of course, the people with the lowest GFR and the highest albuminuria. So even though the relative risk reduction is the same, they have more to gain because on an absolute scale, a 20% reduction in risk on top of a higher relative risk on top of a high event rate is a greater overall clinical benefit. The reason I bring this up is if you look at real-world data, people with CKD at advanced stages are actually less likely to get SGLT2s, finerenone, or even ACEs or ARBs. So there's a risk treatment paradox, meaning people are afraid to use these agents because they're worried about side effects like hyperkalemia, GFR dip, but yet they have the most to gain. So we need to match intensity of risk to intensity of therapy. And then came the Fine Heart study, published about 18 months ago. This was the heart failure preserved ejection fraction study with finerenone, with or without, well, this was with diabetes. But across the board, whether you look at kidney events or cardiovascular events, even including mortality benefit, this agent provides additional protection. Also, I'd like to point out that these are primarily not working through a blood pressure mechanism and not working as a diuretic as much as these are anti-inflammatory agents. So if we go back to why we treat the disease, remember hemodynamic, metabolic, inflammatory. With SGLT2s, we're going to get mainly a hemodynamic effect. Here, we're going to mainly get an anti-inflammatory effect. So it turns out, for example, remember the tubule interstitial disease we looked at? So SGLT2s are going to be mainly working up here on glomerular hypertension. These agents work down here in the interstitium, so we're now attacking another mechanism. We're going after the disease in a complementary manner because on these cells, and particularly immune cells like macrophages, they're mineralocorticoid receptors, and when the non-steroidal MRA, which has a particular affinity for these types of receptors on these cells, we prevent translocation of the receptor to the nucleus and block upregulation of the box at the bottom, inflammatory and fibrotic factors that I showed you in that conceptual model. So now we have two things, and they, on top of ACE or ARBs, every one of these are working in complementary ways to get rid of the pathophysiologic basis for GFR decline and albuminuria. So now what about GLP-1s? I mean, this is the story of the day. I'm going to try to go through this quickly because I want to get to your case. But this really is, I think, the biggest story. Again, I'll admit my biases. I've been involved in all of this work. But these agents have the broadest effect yet across metabolism, cardiovascular, and kidney disease. So they came to us through the same path as the SGLT2, cardiovascular safety for new glucose-lowering agents. Again, another big win across the board, particularly for atherosclerosis. And for the first time with another class of glucose-lowering agents, they actually reduce cardiovascular death, liraglutide and Leader and semaglutide and Pioneer 6. And similar to the SGLT2, in the kidney outcomes, which were major secondary outcomes, they decreased macroalbuminuria. But what distinguishes these agents from SGLT2s is they slow eGFR decline, and they can be used even in late-stage CKD. They maintain metabolic efficacy for weight and glucose, but they also have highly effective benefits on preservation of kidney function. And again, the kidney and cardiovascular benefits were present even in CKD. So in meta-analyzing the CVOTs, using a kidney outcome, just as I mentioned, with albuminuria and GFR outcomes, predicted about a 21% relative risk reduction. Not quite so much if you pull the albuminuria outcome out, but you have to ask who's in the study. These were people selected for high cardiovascular risk. Most did not have kidney disease. They had type 2 diabetes. And so when the trials go 2 years, you're going to have a lot more albuminuria outcomes than GFR outcomes. So this is a power issue. If we dig a little deeper, for example, into two of the CVOTs, Pioneer 6 and Sustain 6, which were semaglutide studies, there was a subset of people who got in with a GFR less than 60, and we look at the slope. You can see here this group had a baseline GFR of 48, completely stable over a year and a half in the SEMA group, whereas there was substantial decline because if they have CKD, they're on the road. With placebo, and the treatment difference at 1 year was over 1 ml per minute. And there was a similar trend in the group with GFR above 60, but not quite as pronounced because they weren't losing kidney function as fast. The reason we cared about this is we knew from an abundance of prior data that if that slope difference was more than 0.75, it would be highly predictive that over time it would prevent kidney failure. So that's why we cared about hitting this number, which was 1.06. And then looking further into the study done with the lowest GFR yet, a mean of 35 at entries, and most had macroalbuminuria. So they were on the fast track to disaster. So even over 1 year, you can see, oops, The insulin-treated group in green had progressive decline, whereas this was stabilized by either dose of dulaglutide, and this is just the 26 and 52-week data. Again, in this group showing significant decline quickly with insulin treatment that's aggregated by either dose of dulaglutide. So this is what led to FLOW. This was the first and only kidney outcomes trial with a GLP-1. Fourth trial in the history of our field, stopped early for positive efficacy. And the hazard ratio was 0.6. And I'll tell you why I put the tick box here, because it has to do with something we call hierarchical testing. And I just want to shout out for FLOW that it's the only trial of this and all the CVOTs that hit every outcome in terms of risk reduction. So this is the primary kidney outcome. I won't read it to you chapter and verse. It's the same as usual. Kidney failure or 50% or more GFR decline or death from kidney or CV causes. And I'm not repeating the heat map. I just want to tell you that 93% were high or very high risk. So this is the highest risk group studied across all the SGLT2 or GLP-1 trials, including credence, STAPA, CKD, and IMPA kidney. So we intentionally enrolled a very high risk group of people. And now let me show you what happened. So this is what we mean by hierarchical testing. Our primary outcome was that kidney outcome. But if we won on that, we could test these other what are called confirmatory outcomes. And it's important from a methodologic standpoint, rigor, confidence in the data, but it's also what will drive the FDA approval and what you can use these drugs to treat. We won on slope, that's rate of GFR decline. We won on MACE, and we won on, most importantly, to my mind, all-cause mortality. So here's the kidney outcome. This trial was also stopped early. It went 3.4 years, but note that nearly 1 in 4 placebo patients had a primary outcome event. That's a very high rate. Reduced 0.76 because we stopped early for methodologic reasons. We had to drop the p-value to 0.03 to claim significance. That's called spending alpha. We didn't, because that increases the chance of a false positive finding. So you have to have a more rigorous statistical bar to claim superiority, and we met that very handily. Here's the MACE outcome. Again, if you want to find people who are going to have a lot of MACE events, pick a group of people with type 2 diabetes and CKD. If you look at the CVOTs, on an absolute scale, this occurred in 1 in 7 patients. This is higher than any of the CVOTs except SELECT. And similar to those CVOTs, hazard ratio 0.18, they've all shown about a 20% relative risk reduction, reproduced here exactly. And then finally, my favorite outcome, the most important one of all, saving lives. 1 in 6 people died during the trial. And we have a 20% reduction in all-cause mortality in a group of people highly likely to die. And this has actually led to the approval of semaglutide for the treatment of people with type 2 diabetes and CKD with the express goals to preserve kidney function, prevent kidney failure, prevent MACE events, and prevent death. It is the only drug in nephrology, and I would say probably in much of medicine, that has an indication to prevent death. So if you think of all the conditions you treat in primary care, how many treatments do you have where the indication is not dead? Pretty powerful. So this is the number needed to treat at 3 years, 20 for a primary kidney outcome, 45 for MACE, and death due to any cause. And again, especially in primary care, you look at a lot of these types of metrics because they're very pragmatic of how many people do you have to treat in clinical trials. If these numbers, are less than 100 in a cardiovascular trial, they say it's effective. I mean, less than 50, you're getting down to really very acceptable NNTs over a return on investment at 3 years. Also, I'm going to call out the heart failure benefit, about a 30% reduction in those with pre-existing heart failure, but also what we showed in FLOW for the first time in a CKD population is primary prevention of heart failure. So that's the group that had no heart failure at baseline and a hazard ratio for those people also in the range of 30%. And that's super important, right? Because even if they didn't have heart failure to begin with, they're highly likely to get it and it takes them out. These drugs, another mechanism. Again, I'm not going to belabor it. I just want to tell you it's not working the same way as any of the other drugs. These are preclinical models. My laboratory did many of them. We looked at type 1 and type 2 models, different agents. Yes, there is some healing of the glomerulus. Again, this is a cartoon version of the histology I showed you earlier. But where we see the really profound benefit is a reduction in periglomerular inflammatory cells and immune cells. And it turns out that there are GLP-1 receptors in kidney cells, particularly in endothelial and proximal tubular cells. But we think the main target is on the immune invaders, macrophages and T lymphocytes, that are then downregulated. When the GLP-1 receptor binds a macrophage, it downregulates production of chemokines and cytokines through blocking NF-kappa beta, a well-recognized transcription factor for inflammation, but it also suppresses production of reactive oxygen species and upregulates hemoxygenase, which disposes of ROS. So now what we really say, for both non-diabetic and diabetic kidney disease, we have four pillars of therapy. For diabetes, it is now established RAS, SGLT2, nonsteroidal MRA, and GLP-1s. Non-diabetic, there's some specific disease-targeted therapies. We won't talk about that today. For example, IgA nephropathy could probably be curable now with the treatments that we have. But in addition, they will need therapies that are going to prevent progressive nephron loss, right? Because as a nephron dies, no matter what the cause, let's say IgA nephropathy, they are going to have single nephron hyperfiltration. It's the kidney's humble attempt to maintain kidney function with nephron dropout, but it's at the same time nephron suicide. It's like, driving a car 100 miles an hour and eventually the engine's going to burn out too quickly. And though really for every cause of CKD, there should be background RAS and SGLT2, even if you're giving like an immune modulating therapy. There are additional therapies under study that are quote, nephroprotective. What can we expect to get out of this? This is modeling data, but to the extent that we have real data on combination therapy, it's holding up very nicely. Now, this would be for type 2 diabetes because that's where most of the studies have been done. But you can see we would project that if people got SGLT2, GLP-1, and a nonsteroidal MRA, we could get down the risk of those kidney outcomes, and that includes kidney failure and substantial loss of function by 60%. All-cause mortality is projected to be reduced by a third. And if you want to jump to the cardiovascular outcomes, again in CKD, where this is the major competing risk that has to be recognized on top of the kidney outcomes, MACE events by at least a third, heart failure more than 50%, and cardiovascular death a third. And again, I'm just showing you this is data back to the issue of we've got to not only get people on therapies, but keep them on therapies. This is again from my data set showing where that 70% came from, but the high dropout rate even here as early as 90 days. And this is also from that registry. It was presented at Kidney Week through the end of 2024. We have gotten better on use of ACE and ARBs and maintaining them, but MRAs and finerenone in particular are almost non-existent. Finerenone wasn't on the market till 2022, but we weren't even up to 1% of the MRA use. Mostly people are using other agents. And then if you look at SGLT2 and GLP-1 over time, it's creeped up. We got to 20% by 2024, but Vlado Perkovic, who I gave these data to present at his opening plenary, made the point that if we keep crawling along at this pace, we'll meet that bar of optimal implementation at 17 years. So we do need to have some sense of urgency. Time is kidneys, time is hearts, and maybe this is an opener to the primary care discussion. This is just a perspective piece that several of us wrote that this is a huge number of people. None of us can do it all. Again, back to team sport. There are a number of patients, though, who can be effectively managed by the excellent primary care that you all provide. And particularly when people are in the yellow and green boxes where we're talking about screening and early treatment with SGLT2s and ACEs or ARBs, those probably can be very effectively managed in primary care. Once people start hitting the higher risk groups and we're adding on finerenone and we're adding on GLP-1 and the complexity increases, we have recommended that that be a consideration for when we would join you in co-managing these patients, and that we need to take a quicker approach than we've put in the guidelines because we can walk back to it. But if you go to those event curves, you see that they tick up really fast. And, CKD we need to view as no longer some slowly progressive thing where people are sort of crawling along to kidney disease. They're dying fast. And the agents that we have reduce the mortality, particularly the cardiovascular mortality. And among the living, they keep people's kidneys working. So that's pretty much of a gift if we can give it to people, right? So here are the take-home points. SGLT2 with an ACE or ARB is first line now for CKD, irrespective of diabetes, and it's due to the totality of benefits, not one. Kidney, cardiovascular survival. And then in people who have persistent elevated risk despite first-line therapy, particularly is marked by persistent albuminuria, hyperglycemia, cardiovascular disease, obesity. Then we're going to add these other agents like non-steroidal MRAs and GLP-1s. And I do want to call out that semaglutide is the first GLP-1 shown to improve kidney, cardiovascular, and survival outcomes. And truthfully, we don't have this data for SGLT2s, although they are very effective therapies. When you look at the metabolic benefits on diabetes and weight management, as well as CVD benefits, for kidney benefits, at least from my viewpoint, it is the most comprehensive therapy that we have. But we have to get to detection and awareness and implementation to realize these benefits. So I'm sorry if this went on too long. I'm going to stop now and turn it over to you.
Dr. Tuttle, thank you so much. Just so many questions and comments and things like that I think John and I have as we're sitting here talking. Love the talk and just to think about it, or this group here, right, guys? We have 250,000 patients that we're seeing in primary care across all of our primary care departments. So, even if we do a conservative percent of those patients having these conditions, that literally translates into thousands of lives saved if we can do this. And so I think just who says primary care doesn't matter, guys? It matters a hell of a lot, and I think we can do this. I think we have a few implementation type of questions, right? So I think the data you say is so compelling. We got to get better actually translating this into our clinical care. And I think one of the questions is here at KU, I don't know that we're screening everybody appropriately. So I think even just identifying those patients, we're very good at identifying diabetic patients with microalbuminuria because we have tools set in our health maintenance tab and alerts and other things like that. We don't really have system-based ways of screening for some of these other things, just CKD with albuminuria, hypertension. So I guess really the heart of that question here, Dr. Tuttle, is from a population health level, should we be screening everybody with CKD stage 3, pre-diabetes, hypertension, and I think there was another one that you had on your list?
Yes, and I want to be clear, that's a really important question, and it also is going to map back to the U.S. Preventive Health Services Task Force. So the ADA, the KDIGO, which are the International Kidney Guidelines, and American Heart Association, AHA, ACC, and other guidelines throughout the world, but I'll bring those up because those are in the American context, which is where you are in Kansas, all recommend screening of all people with diabetes. In type 1, the recommendation is to start at 5 years because we know the onset of diabetes and we rarely see CKD before 5 years. Okay. All people with hypertension, all people with cardiovascular disease, and all people with a family history of kidney disease. And cardiovascular disease, what are we talking about? ASCVD and heart failure, particularly, because of the intersecting risks. The U.S. Preventive Health Services Task Force, which I know is a very important organization and guides so much of primary care, was tasked with reevaluating their recommendations for CKD screening. I want to be clear that they did not include any of those groups because they said, well, there are already recommendations from professional organizations to screen those people. So their position was, should we screen for CKD in people who aren't in those groups in the general population, and came up with the answer being no. But it's been misinterpreted to say that we shouldn't screen for CKD. So I think it's really important to have a moment because this is where so much is going to happen in primary care. I think that, that's the subject of future research. Some people have done some projections that, if you used SGLT2 inhibitors and you identified people who had CKD who weren't in these risk groups, it would still be cost effective. Let's just put that to the side. There's still debate about that. But there really is no debate, again, for diabetes, hypertension, family history of kidney disease. And again, you're in the home of PKD, so you better be screening there. If you remember good old Dr. Grantham.
Yeah.
So that's an example of a family history where if somebody has a family history of that genetic disease, the family member should be appropriately screened. And then again, if you take heart failure and ASCVD, again, I'd be interested in your perspectives, but I'm going to guess that's the majority of patients in your practices. It's
Yeah.
two-thirds anyway.
Yeah, I think you're exactly right. So we'll look to Dr. Gupta there to help us implement better tools across our primary care systems. But all right, Dr. Gupta, you got a question there?
I do have a question. Yes. Thank you for the wonderful presentation. Enjoyed it again. It was beautiful. My question here is in terms of screening. When we screen for colon cancer, breast cancer, there's metrics. Insurance companies keep reminding people to test it. Here, we now have none of that. So
Right.
I think we have partners, potential partners, in insurers. Have we engaged them, or does it make sense to engage them? I think implementation gets easier if there are more parties sharing the same cause.
Oh, I totally agree. And I think that's where we need health policy and health system priorities. Um, Obviously, there's a lot going on in the United States, but health policy should still be important. And I do think that that's where our professional organizations, and it's not just one, right? Certainly, as nephrologists, that would be the American Society of Nephrology, but I see that as important for the American College of Physicians, the American Association of Family Practice, ADA, ACC, AHA, to be a united front on health policy. I'm also serving on the AHA-ACC committee for the cardiovascular kidney metabolic guideline, which is going to be released in a few weeks at the ACC meeting. They're calling very strongly, we are calling very strongly for albuminuria to become routine along with GFR across cardiovascular medicine. That's the kind of voice that we need in the room. I know you're interested in implementation. Again, when we can get back to focusing on health policy in this country, I think this should be a top priority. And in primary care, I'm interested in your reflections. I was at another institution, much like yours. It was at UCLA, and I was meeting with the chair of medicine, who's a primary care physician. And she said, we just haven't set priorities. So you're back to like cancer screening. Of course, that's a priority. Like colon cancer saves lives. Why do we screen for colon cancer? Because it's been shown to save lives, right? And so, of course, we should do that. But beyond some of those other high return screenings, there's a lot of stuff that's probably being done that isn't so high priority. And we kind of do the same screening across different groups of people. Maybe it should be customized to the patient's risk too. So, you know, maybe not every old lady needs a DEXA scan, but maybe that person should be who has diabetes and hypertension. They're more likely to get a DEXA scan than an albuminuria test. Maybe that needs some reassessment, is what should be the priorities for screening based on the patient profile. Because let's admit, we can all only do so much. So if you can do three things, what three things would be most important for the person in the room with you? There's somebody else who might need the DEXA scan more. But I'm bringing that up because I've had that personal experience. And I'm like, I'm not sure that that's so relevant. So, if you could do everything, you would, but we can't. So, how do you match the screening to the patient preferences, priorities, and phenotype?
Yeah. Well, I think the good thing here also in support of what we want to do is the CDC does recommend screening for high risk populations. So
Yeah.
it's not in the kidney realm, it's there even outside the kidney nephrology realm. And I think Dr. Cupford and some others here at KU might have some influence with ACP. So we can talk about that too.
Yeah, I'll let Brandon know about that. I feel like the microalbuminuria thing is probably the biggest sticking point, or some sort of albumin screening, because it's like we
Yeah.
can't treat anything that we don't know that we have in front of us.
Right.
And so a
Right.
big problem
Right.
with how we do things in primary care is we see CKD3 or diabetes, and we're doing microalbuminuria, but I think we're missing a lot of patients with albumin wasting, and they don't have CKD screaming in your face. And so I think our biggest thing will be we need to start screening people a lot more for at least this one thing. Because we can't use any of these measures. We can't use GLP-1s or MRAs or anything unless we know what we're treating. And so,
Right.
like for our group, like a big take-home point is like check their urine. Like we're all getting GFRs, just check their urine. Just make sure you're doing a good job.
Well, you know, Brandon, the other reason that's so important is the risk, the residual risk actually resides in the albuminuria. So if you take somebody with the same GFR, let's say 45, and they have a UACR of 20 versus 300, what's going to predict the cardiovascular events, mortality events, and the kidney failure events is the albuminuria. So that person with a UACR of 100 needs to be fast-tracked on a GDMT. If their UACR is 30 and you have them on an SGLT2 and an ACE or an ARB and they don't need a GLP-1 for weight or diabetes management or heart disease, then that's all you need to do. And that's a very appropriate patient for you all to see. On the other hand, if that person has a UACR of 600 and they have heart failure, that may be a situation where, yes, you know, you are going to be at center of their care, but that may be where you want to confer with cardiology and nephrology about, well, what would be the next best drug for this patient, and then what monitoring should occur. And then if there is a question about, is the GFR dip too much? What level of potassium can we tolerate? And it will depend on, you know, your own comfort and skills with that in internal medicine. There are probably a lot of internists who can handle that pretty well, and some others who might like to have advice on that. But I think we need to start thinking a little more granularly about risk. And albuminuria is where the residual risk will lie.
Okay. We had like 5 minutes over, and the fact that we have like 40 people still on is so awesome. So like it just speaks, no. This is like so wonderful. Like we can't thank you enough. This is such a great talk. It's great to probe you a little bit. And this is just so high yield for our group. So we can't thank you enough. Thank you for nephrology who's joined. Thank you, everyone. And Dr. Tuttle, have a great trip.
Okay, and thank you for your patience with our little bit of a technology hiccup at the beginning. The other thing too, I just want to answer it. Spencer Hill, yes, you should repeat an elevated UACR. The guidelines say 3 to 6 months, but I'm going to be a little provocative and say I'd like to say 4 to 6 weeks, because if it is elevated, I want to get these people that, especially like what we just talked about, we want to quickly get those people on therapy. Again, I happy if you all want to share my slides, but if you want to look at those event rates, especially the heart failure event rates go up very quickly, and they're reduced by these therapies. So I think I think that we and the guidelines took an old approach as we've seen newer data and we see now in real time how quickly these events occur. I think it should drive us to move more quickly. Again, completely acknowledging that everyone's busy. It's hard to see people frequently. But that's too where we can think about how do we work smarter, not harder, to get the care delivered and get it done in a timely fashion.
Yeah, great question, Spencer. All right, Dr. Tuttle, thank you so much. We appreciate your time.
Okay. Okay, thank you.
Bye,
Bye-bye.
everyone.